and Strategic Management, the courses in the Master of Health Administration and Master of Health Informatics programs. Dr. Kazley currently serves as Program Director in the Master of Science and Health Informatics program at MUSC. In her previous role as Program Director of the MSHI Program, she oversaw the transition from content to competency-based education and evaluation. She also has published more than 60 peer-reviewed research articles. And in addition to that, I have the privilege and pleasure of working with Dr. Abby on the Board of Directors for South Carolina HIMSS, as she also serves as our chapter treasurer. And so thank you again, Dr. Kazley, for serving as our moderator today. And I'm now going to turn it over to Tom McDermott, who again represents our sponsor and provider for this session. Thank you, Tom. I'll turn it over to you.
Great. Well, on behalf of Imprivata, I'm very happy to sponsor South Carolina HIMSS. We've been a sponsor for a number of years, and it's always wonderful to take part in these events. On behalf of Imprivata too, it's great. Many of the panelists are actually existing customers of ours, so thank you for being customers, and I think many of the attendees are as well. As a company, we continue to build out our digital identity framework, and all that information can be found right on our website at imprivata.com. I really want the group to focus on the panelists today. So again, on behalf of Imprivata, very happy to be a sponsor, and I'll throw it back over to Abby.
Thank you, Tom, and thank you, Imprivata, for your generous sponsorship of this panel and for your support of South Carolina HIMSS. I am very pleased to moderate the session today, and it's especially exciting because we have such wonderful expertise. So I'm going to go ahead now and tell you a little bit about all four of the panelists that will jointly answer some of the questions that I have provided today, and then you will also have an opportunity at the end to ask them any questions you may have. So first, Chris Belmont is the Vice President and Chief Information Officer of Memorial Hospital and Physician Clinics. He joined Memorial Hospital and Physician Clinics with more than 35 years of executive leadership, business development, and consulting experience in healthcare and information technology. Most recently as the Executive Vice President of Operations and Strategy at the HCI Group, Tech Mahindra in Jacksonville, and Chief Executive Officer at Intelligent Retinal Imaging Systems in Pensacola. In addition, Belmont has previously served as Vice President and Chief Information Officer at the University of Texas MD Anderson Cancer Center, Houston, as well as the System Vice President and Chief Information Officer at Ochsner Health System, New Orleans. He led the EMR transformation projects at both organizations while transforming the Information Services Division to be tightly aligned with the organization's vision, direction, and outcomes. He holds a BS and an MBA from Southeastern Louisiana University in Hammond, Louisiana. Our second panelist is Mark Daniels, the Chief Technology Officer of Information Solutions at the Medical University of South Carolina. Mark Daniels is the Chief Technology Officer and Assistant Professor of Health Informatics at the Medical University of South Carolina. He holds a PhD in computer science, is a HIMSS Fellow, and has over 30 years of information technology experience across both the public and private sectors. In his current role, he's responsible for leading IT collaborations with strategic partners, leading technology innovation efforts, evaluating emerging technologies, and leading the IT enterprise architecture practice. And I will tell you, he's very much a beloved faculty member in the Master of Science of Health Informatics program at MUSC. Our third panelist is Skip Rollins, and he's the Chief Information Officer and Chief Information Security Officer at Freeman Health System in Missouri. He received a BBA degree from Faulkner University in 1990, and previously he's held multiple senior leadership positions in organizations in banking, retail, as well as healthcare industries. Skip was the president of Integration Resource Group for 15 years, and he's known as a forward-thinking innovator in the healthcare IT industry. Our final panelist is Dr. Anna Shalkham. She's the Chief Information Officer and Chief Medical Information Officer at Lexington Medical Center. As CIO, she oversees IT strategy and operations for the organization. Her specific interests include EHR implementation and optimization with an emphasis on clinical decision support, patient safety, and patient experience. Dr. Shalkham is a diplomat in clinical informatics from the American Board of Preventive Medicine, a fellow in the American College of Emergency Physicians, and a member of the American Medical Informatics Association. She holds a BA in Environmental Science from Duke University and an MD from the Medical University of South Carolina. Dr. Shalkham completed her residency training in emergency medicine at NYU Bellevue Hospital Center, where she also served as chief medical resident. She holds a master's in public health from Arnold School of Public Health at the University of South Carolina, and she continues to practice emergency medicine at Lexington Medical Center. So as you can see, we are honestly surrounded by such wonderful expertise, and it's a real pleasure to hear from so many very experienced leaders within our field. So I'm going to start with the first question, and I'm going to ask this question, and this is going to be the one that's going to be directed to all of you. So I'd ask that all four of our panelists take a turn answering this question, and then beyond that, we can sort of take turns with each of the questions. The first question is, what's the question you are most tired of hearing on the subject of healthcare IT, and what would you like to say about it so you never have to answer it again? Mark, would you like to start us off?
Sure. So something that I'm asked on a pretty regular basis is, how is healthcare IT going to digitally transform healthcare? Digital transformation is one of the current buzzwords that's out there. Everybody wants to talk about it. And I think that part of the problem that I have is lots of people don't really understand what it is. Mm-hmm. Digital transformation is business transformation. It's not IT led. It may be IT implemented. And, I'm all for it. We really need to engage our users and our business leaders to help figure out how they want to transform the business. And then we'll step in and help them make that happen. But there seems to be this feeling that somehow IT is going to step in and digitally transform healthcare. And that's not the way it works. So, I wish people understood that and could get on board and we could all move together down this path.
That's a great point. Well, hopefully you're going to, just by sharing this today, start moving us in the right direction. Dr. Shalkham, would you like to share with us which question you're most often asked?
Sure. And this one made me chuckle, and I'll take this from kind of the physician angle. But unfortunately, I do still get on occasion questions about why do we have to use an EHR? Why can't we go back to paper? As you can imagine, I get this question more infrequently now as new grads are coming out and they've only practiced in a world with an EHR. But I'll still have particularly some of my older physicians who have been slow to adopt EHR technology that will ask me why they can't go back to doing things the old way. Obviously, I'm tired of answering the question. I'm sure you guys get the same questions as well. Because to me, it seems quite evident. We've been up on an EHR for 10 years. There are a lot of different reasons why it makes a lot of sense. And depending on who's asking the question, I answer with either the benefits of patient safety features or reporting tools, communication with patients. There are a lot of different angles you can take. What I find interesting now is that now that we've lived through the COVID pandemic and continue to manage through it, I rarely get this question anymore. So it's been interesting to see how the COVID crisis has forced our physicians to have kind of a very real and urgent need for health IT to help them manage whether it's patient care, rapid testing, infection control management. It really has become a new world. So I am happy to say I was very tired of hearing that question, and over the last 6 months, I've heard it much more infrequently. So
I definitely call that a victory. Thank you. Skip, would you let us know what question you're tired of being asked, please?
So this one will probably be a little less traditional. The question I get asked the most is what keeps me awake at night as a CIO. I hate that question. It comes from a place of not really understanding what a CIO's priorities are, and sometimes it's done in an effort to try to get you to give them something to hook into to sell you something. But more often than not, I get that question. But the thing that concerns me the most that I would like to say is how can we make the patient's experience better? That's the thing that I strive for in everything that I do. Everything that we do as an IT organization is all about making sure that patient has a good experience at our facility.
Sounds great. I love that it's being tied back to the mission of the organization. Chris, would you please share with us what question you're tired of being asked?
Yeah, I'll be glad to. Hopefully you can hear me. You know, I'm going to go down the cost route. Unfortunately, that's where we are today. Is, you know, we're always being challenged. Why does it cost so much? I just had a board meeting actually Monday, and the discussion was around that. Why are we spending so much? You know, and once I broke it down by more or less functional areas, and then broke it down even further by the different departments and different tools we have, and then even by department and number of people and so on, it made more sense to them. But it's this constant justification of, I want to do this digital, transparent, paperless, high productive, high availability, highly secure release of services to the business, but also want it free and fast and now with no disruption. So that's that dilemma we're always in our roles, is how do we provide that excellent service, meet everyone's expectation, but do it for very little. So I don't know how to answer it finally, but I'd love for it never to happen again. And by the way, I'm not buying this stuff, and I'm not putting all this expense out for the IT department. Obviously, the vast majority is for the rest of the organization.
Those are great points. Okay, the second question that I'm going to ask, and please feel free, any of the panelists may, we can rotate around, or we can have a couple people answer if someone feels especially compelled, please do so. We know that COVID-19 has had a tremendous impact on everything this year. What effects do you think will be lasting or lead to long-term changes in the healthcare IT industry?
I think work from home is here to stay. I think what we're doing right now, both from a working perspective as well as from a telemedicine perspective, is here to stay. I mean, we may back off on it, don't get me wrong, but I think people are more accepting of it. They're getting used to it. The tools are maturing faster than we can keep up with them. The vendors are leapfrogging each other weekly on bringing out either new features or the features that their competitors have. And I think we're going to continue to see this virtual environment all throughout healthcare going forward.
I'll jump in and second that. I think probably the most profound change that's here to stay, again, is that growth in the virtual care delivery. And really, it's patient adoption, it's provider adoption, it's patient expectation now that they have that as an option for care. And probably even some of our most resistant providers before, who had no interest in engaging patients virtually, soon realized that some care, albeit virtual, was better than no care, right? So when patients were scared, they didn't want to come into the office for routine care. That's when we really saw providers reaching out to IT for help with tools and wanting to explore different avenues. So I think the appetite for virtual care is here to stay. And I'd like to think that the payer movement, in terms of their interest in reimbursing these services, is also here to stay. I do feel like they can't go back to their pre-COVID stance for the most part. I don't think that is sustainable for them, private or government payers. But it remains to be seen what kind of staying power we'll have in terms of where all the payers will settle out long term.
I think one of the things that I like what's happening, and I think the longer that this draws out, not that I'm in favor of that by any means, in fact 2020 can't end fast enough, but the longer this goes on, I think our decision-making process is being matured to the point where I think we're working closer together. You know, having lived on the Gulf Coast for a long time and working in New Orleans and Houston and now in Gulfport, you know, we're used to weather events, for example. And when an event comes in, we somehow figure out how to make quick, snap, good decisions based on the information we have, and it works out and we get through these disasters. And I think as COVID has shown us is that we have been in this mode for, you know, several months, since February at least, and it's forcing us to understand how we make decisions. We're looking at, you know, we're making, you know, macro and micro decisions at the same time, and I'm hoping that will stick and allow us to think more on our feet, be a lot more agile, and you know, and accelerate some decisions, but also second guess others.
And I would say that probably the thing that I've seen is it's legitimized a lot of things that the CIO community has been telling the leadership for a long time about virtual medicine and things like that. I think that for me as in a community health system where we're not in a big urban area, but we've been talking about virtual medicine for a long time. We've been and now we went from 0 to 100 in a month, and now we've learned so much about the tools, and honestly learned a lot of I think bad assumptions about the capabilities of our customers out there in the community. We assume that they know how to use a smartphone. We assume that they have a good internet connection or a good cell connection, and what we found a lot of it is that a lot of our plans, our assumptions that we made around rolling out virtual medicine were kind of invalidated because our sickest customers are the ones that are least experienced using the smartphone, smart device that you need them to use a lot of times to have that virtual experience. So we're dropping back and looking at our whole strategy around that as a result of that, and I think in the end we'll be better for it.
I think another, if you don't mind me adding one more thing, it kind of combines what Skip was saying and also through the other conversations about working remote. I think it also opens up the IT department getting a little bit back on the cost component too, in looking at alternatives of the way we staff our teams. Can we do more on-demand staffing? I don't have to locate, a Cerner expert in Gulfport. I can access any of them anywhere, and it's becoming much more accessible. Also, the big heavy lift on an EMR implementation or any transformation of bringing people in and doing at-the-elbow support, that's being more embraced virtually as well. So I think it's introducing some alternatives on the way we deliver our services as well.
I think it's really good news to hear that there may be more flexibility in staffing and workplaces, but it's also especially exciting to hear all of you highlight the growth and hopefully the staying power of virtual care, with the hope that access for our most vulnerable patients with the support that Skip has indicated is needed is going to continue to grow, and hopefully along with that, the quality of healthcare. So the next question I have is sort of a two-part question. How has the industry changed in the past 5 years, and what do you predict will happen in the next 5 to 10 years? So get out your crystal balls, please.
So I'll go first on that one. For me, as a CIO, I'm no longer seen as a technician. I'm no longer seen as a guy that works in my office and just makes the magic happen. We're involved in business decisions now. We're pulled into the meetings with the community leaders and things like that to participate and help give perspective about how we can make those initiatives happen. So that didn't happen in a lot of organizations until the executive team and honestly, in our case, our board members pushed for IT to be more involved in the business side of what we're doing. So for me, that in the last 5 years, I would say that's probably the biggest change. And I'll go back to what I said previously. In the next 5 to 10 years, I firmly believe that we will be enabling our patients to participate in their healthcare from their home. And that I think that's going to take a lot of shapes in different ways, with us providing them tools that actually allow us to monitor their care and participate in their care and give them more of a role in how they're cared for by their care providers.
I think we've over the last 5 years kind of demystified the technology piece. Just because technology is so prevalent, everybody has it in their hand now, but it also set some expectations that are very hard for us as CIOs or IT professionals to deliver upon. So expectations are high. Our ability to pivot and deliver on those expectations is much more challenging. What most people want is you drop in an app or download an app from the App Store, and then it says, hey, would you like to connect with your Google or your Facebook account? And you're up and running in minutes. And so that's getting to be the expectation, but our ability to get there is slim. So I'm hoping over the next 5 years we'll continue to mature and head in that direction. I think a lot of the traditional vendor and a product developers need to help us get there as well. The cloud is going to be beautiful as far as elasticity and so on, but if the pricing doesn't follow and we're still paying for per user versus per second or per microsecond, we are going to we're going to still be in somewhat of the same dilemma we're in.
Yeah. And I follow the cloud comment with what I was going to mention is that I think in healthcare we are much more willing to embrace a lot of the software as a service, platform as a service technologies that not that long ago we were saying, ooh, HIPAA, we can't do that. We're now embracing it. We understand it better. The vendors understand us better. I see this shift where we're now seeing more and more of these large applications that are more best practice based, and we don't have to do as much customization to them. They have more of this always updated. We don't have to do these big updates. They're more like Facebook, where there's updates happening all the time and you just don't realize it. We're going down the path of a new ERP, and that's the new way of doing things. We're seeing a lot of this. I think that this will continue. I think that in the future we will see the end of large local data centers. I agree with Chris. The price has to keep coming down, but I think it's what's going to happen. I would predict we'll start to see something that will start to look a little bit like the old best of breed world, where we're using modern APIs to start hooking cloud-based platforms together to form our ecosystems. And we'll be able to, they'll be more standard. The APIs will be more standard, and we will be able to be more agile and say, we don't like that one anymore. We're going to switch to this other one and be able to make that happen pretty quickly. We're going to see some interesting stuff.
Yeah, or in a similar note, just, here are 4 or 5 choices. Pick the one you like.
Yeah.
Very good. Thank you. So the next question I have is, what is the biggest challenge in the industry at the moment, and what are the most critical changes we must make to face the future effectively?
So I can start with this one. I think it's tough to pinpoint one. There's so many challenges within healthcare right now, and that ranges from aging population, regulatory changes, shifting payer landscape, I think evolving care models. So it really is a lot to maneuver through. I do think our role is obviously to guide our organizations and really work to marry information and technology in such a way that it positions us to handle all of the challenges. And I think that ranges from being educated about what's coming down the pipeline in terms of policy, being involved in policy making. I think that's part of it. And then obviously collaborating and sharing, keeping ahead of what's out there, anticipating what's coming next, being abreast of new technology and adoption, and really, again, guiding our organization as we try to navigate the new landscape.
Very good.
I'll jump in if you don't mind. I'd love to hear the others' opinion on this, but one of the things I think we continually fool ourselves about in the industry, and also even in our, in our IT world, is, are we say we want to be patient-centric, but are we ever? We talk it, but we don't necessarily walk it. At the end of the day, we keep things very confidential about our patients, and is it really the patient's record or is it our record? And we can open it up and we can make this interoperability standards push, but at the end of the day, we treat them as our patients versus treating them as a member of a community or as us participating in their care versus them coming to us. So I'd love to see a shift. I don't know how or when or if I'll even be around to see it, but I'd love to see this shift to where we truly are participating in each individual's care versus them coming to us and us, interacting in an episodic manner.
So Chris, I worked in the banking industry when it was deregulated.
Sure.
And I saw that concept of exactly what you're talking about, is that they're all banking customers. They're not a particular bank's customer. And I I get frustrated with the regulations that encumber us from sharing information about patients with other organizations, even because you're correct, they're not our own, but we don't own them. We participate in their health care. And I think that we should, anything that we can do to help them get better health care, whether it come from our organization or another organization that for a service that we don't offer, we shouldn't say, oh, well, we can't share that. That's private. Well, it's really not. It's their information, and they should be able to share it with whoever they want to share it with. So I totally agree with that, and I wish that healthcare as a whole would see the benefits that banking has seen from sharing their customers' information.
Very good. And you guys have also segued us quite nicely into the next question, where we talk in a little bit about the individuals. So as patients continue to play a larger role in the success of their own health, a focus on consumerism is becoming part of almost all major healthcare systems strategy. Can you please talk a little bit about how your organizations are focusing on this and how you see this changing the way traditional healthcare is delivered, especially as large companies like Amazon, CVS, Apple, Google, and others continue to step into the healthcare arena?
That's a hard question to answer. We have spent a lot of time at Freeman with Apple Health talking to them about how they are doing this and how we can participate in it. And, and honestly, I've learned a lot from talking with them because, their approach is kind of very agnostic. And it's really about the technology enabling the consumer. And we've been working with them, as a vehicle to for our APIs and things like that to try to make sure that we're accommodating the need of the customers and giving them the access to the data that they want that we have in our environment. And it goes back to the previous question of we own that data, so we're not going to share it with anybody. We really don't. And so I think that from my perspective, I'm trying to learn from those organizations that are not healthcare organizations that consumerize what we do have, because we're so caught up in how we've always done it. It's very difficult for us to step back and look at it and holistically and say, here's how we can make it better for the patient, not how we can keep it away from them.
And I think generationally, the consumer, the patients, are very different today than they were not that long ago. They're much more technology savvy. They understand privacy. They understand data. They want to control this stuff. It's theirs in their minds. I mean, I think Apple Health Record is a step in the right direction in their mind. Virtual visits is a step in the right direction in their mind. I think we're going to have to adapt to this. It's a new world from the consumer's perspective, and I think as the population changes, as my parents move on and my kids grow up, things are going to continue in this path. We've got to be able to adapt to these. I think the EMR vendors are starting to see it. I think they're starting to be more accommodating, and they understand they can't keep the data captive either. They have to be willing to set up ways for us to share this. We're not there yet, but we're starting to see that movement, I think.
A little bit.
A little bit.
Yeah.
Well, I have sort of go ahead, Chris.
I was going to say, the group coming through or coming up now, it's not like they want it; they expect it. Mm-hmm. And we've got to get over this competitive, subtle background kind of competitive environment we're in. Is CVS is getting into our space. It's like, no, it's actually a lot more convenient for me to go get a flu shot there. And if we think of it big, it's like, well, let's save, the slots in the clinic here at Memorial for patients that need the slot. And, flu shots, while it's a great data point, it's sort of like, do you have to go to the car dealership to get your oil changed, or do you go through the 5-minute drive-through oil change and get the same absolute actual best care and everything as usual? So how do we shift away from this competitive, that's how we do it environment to this, let's use our resources appropriately environment?
Yeah, I agree. I think there's a whole population of people out there that expect a certain level of technology to be there, and want to be able to get in there and look at their data and in our environments. And I think that we and the EMR vendors have to get past this privacy thing and be willing to provide that information to the customers, because it is their information.
Mm-hmm.
I will say for our organization, in terms of competing with the CVSs and other services, what we've really tried to do is focus on our existing patients and provide them with that same accessibility and variety of services that those other places are providing. So whether that's allowing patients to schedule their own appointments with their PCP, or have on-demand video visits with their PCP, or scheduled visits, what we found is that if you can replicate that same service and it's with a provider that you already have a relationship with, folks are preferentially going to gravitate towards that. We've had pretty good success with that. And then to Skip's point about giving them access to their data, and I think most organizations, in light of the 21st Century Cures Act, are doing the same. Now have adopted a pretty aggressive stance about sending results downstream to patients in a timely manner, really empowering them with much more of their data than they've ever had access to before.
So it sounds like everybody's sort of in agreement that we need to be responsive to what patients need and what they expect, and really pay close attention to that and hopefully move in that direction. Before we move on to a policy question, we have a really good question from one of our audience members about how you are bridging the gap to the patient with the challenges around technology in the community. Skip sort of touched on this initially, that some of the more vulnerable, sicker patients may not have access to technology. Do any of you have examples or ideas to share of how we can overcome this challenge?
Well, we struggle with, and again, I'm speaking for my environment, but we kind of force them to a patient portal to get access to their information. And just by nature, those things are very confusing to look at. It forces them to download something onto their phone, and they may not be even able to do that. So we've been redesigning how we are trying to, with a third-party vendor, how we present that information to our patients, and not necessarily a portal, but more of a data mart, if you will, that they can look at their data, because we make assumptions about what they want to see and how they want to see it, and those assumptions are not always correct. And so bridging that gap is in my mind, is finding a way to give them their data and let them see it the way they want to see it, not the way that we think they should see it.
Yeah. And I think there's two parts. One is the access to connected devices, and other than in some very specific cases, I don't think we've really done a whole lot in that space. I think the other part is the ability to use the devices or use the applications once you get them. And I do think that, like yesterday, I was on a call with our director of telehealth, Dr. McGilligan, and I think they are making a concerted effort to make sure that everything that a patient would touch is as simple and seamless as possible, that we minimize anything they have to download, we minimize the number of links, we minimize the number of things they have to do that could throw them off or confuse them or make them frustrated with the process. I mean, it's a little bit, but I think it does, especially for people that aren't as comfortable with the technology, it just helps them be more successful.
I feel it would be nice if we could, leverage, again, the COVID situation along with education. They're fighting the same issue. How do you get technology into hands across the board so everybody can get the best education? It would be nice if we could learn or piggyback or collaborate with that need, and maybe have and solve two birds, or was it two birds with one stone kind of thing? So it'd be great to see if we could collaborate in that with that industry.
Very good. So moving into the policy. Oh, I'm sorry, go ahead.
I was going to say, I saw the follow-up question the person asked me
Yes.
about how we're doing it. So one of the big things that we did was we stopped trying to use the CCD as the only source of information for the patients, because most all portals are driven with what's in the CCDs. And what we found is that there's a substantial amount of information that's not pertinent in the CCD, and it's really more to satisfy regulatory things rather than provide information to the patient. So we've gone back and looked at direct data feeds from results and things like that to use that to populate the portal rather than just limit it to what's in the CCD.
Very good. Thank you, Skip. So moving into the arena of policy, HIMSS and other healthcare organizations have advocacy programs as policy continues to play a bigger role in healthcare. From your perspective, how is policy impacting healthcare now and potentially in the future? I know we talked a little bit about funding mechanisms for virtual visits and things of that nature. Are there other areas that you think policy is going to impact health?
I do think interoperability policy will become increasingly important. I think we all have recognized during this COVID experience that maybe had we been in a better spot in terms of interoperability, there would have been a lot of efficiencies gained through either reporting, testing, communicating with our state health agencies. So I wouldn't be surprised if now we see increased traction around interoperability policy just to get us up to a spot where we all are using consistent terminology and have ways of communicating such that in the future, hopefully no additional pandemics are on the horizon, but as we have additional challenges, we're better suited to address those.
And just tacking on to that, add a little bit of the research capabilities if we had access, how much faster, how many more data points, how many more subjects could we have identified along the way as well?
From my perspective, I think you're going to see much more transparency about what information that we can share. And you know, when I think about us filtering data for the HIE around the CF42 patients and people like that, I think it encumbers other organizations that might treat those patients. So we need to have more transparency around the information that we have.
And I think things have changed so rapidly over the last 5 or 10 years. The policies have not kept up with them. You always hate to have more policy, but there's a lot of ambiguity out there on what you can and can't do. You know, Skip, what you can and can't share, and in what ways. And I think we need the policies to help provide some guardrails and allow us to do what we need to do, but feel like we're doing them properly and correctly.
But isn't it a little concerning that sometimes we need a policy to force us to do the right thing?
Yes, sure.
Yeah.
Yes. You know, there's common sense, and you know, and then there's, but a lot of the regulatory things that we deal with, as CIOs, our healthcare IT folks, it keeps us from being able to do things that we also think we should be able to do.
You know, and then you think about policy and even some of the initiatives around pop health and things. It's a shame we just don't take those things literal, because there's always this financial hook to it that might be the catalyst to get us to trigger and do the right thing. And then next thing you know, we're forcing ourselves into harvesting as much of the incentives as possible versus saying, okay, can we do the right thing and do we take care of the patient better? Really, that's my observation.
I think those are really great points. We have gotten official word that we are encouraged to extend our session until 1 o'clock instead of 12:45 because we're having such a wonderful discussion. So I hope you all are able to stick around if possible. I have one more final question for each of you, and then we'll open it up to the audience. And I actually really like this final question. In an important part of effective change management in capturing previous lessons learned, do you remember a specific example of where you wished you, your organization, or the healthcare industry overall had done something differently? And if you were to do it over, what would you change?
Wow.
So many lessons learned, right?
It's hard to think of a specific example. I will tell you, I think there's some basics in change management that we all know, and yet you have these times when you misstep, whether it's implementing a new application, changing a process or a workflow or procedure. And I always come back to the things that matter are the starting with the why, right? So explaining to everyone why you're doing what you're doing, and
Right.
then trying to involve end users in some part of the process, right? So if it's not, they can't be involved in vendor selection, fine, but at least maybe they can be involved in some of the build, or maybe it's end user testing or one of those things. I find that anytime I've had a significant misstep, it's because I skimped on one of those things. And usually it's bringing the end users and operations along throughout the whole process, having them feel connected. Even if it was a stellar implementation, it's a great product and it's working well, you really sacrifice something in terms of buy-in if you don't hit those marks before.
I totally agree, and I think that probably the biggest mistake that we make, and I'm going to talk about the IT organization, is that we kind of treat a lot of the things that we do on a need-to-know basis, and we're not really transparent, and in my experience has been that a lot of times, and there's some really good documentation out there in the industry to back this up, the more you involve your users, the more you let them participate in the decision-making process, the better the outcome for what you're doing. So from my perspective, if I had it to do over again, I'd be a lot more willing to bring that broader group of people in and let them have a voice in the process, especially when you're talking about EMR installs and things like that. So they understand the whys and they understand the limitations and they understand, that a lot of it's regulated and we're forced to do it. And a lot of times we don't tell them that, and we end up having a almost combative relationship with them over the EMR when really we're just trying to do what we're regulated to do.
Mm-hmm.
Yeah, and I think that that for us, prioritization is something that I would have really done differently if we could do it all over again. It's not as much about what we did, but it's about what priority we did things in. And then of course you're limited by resources, you're limited by funding. So the stuff at the bottom of your list often doesn't get done. And if IS or IT is a major part of that prioritization process, then we may not actually be doing what the business needs us to do. The business really, with some exceptions, really needs to own the majority of that prioritization, and they need to own, the fact that some things aren't higher than others, and they need to be able to from a business perspective, justify why they want one thing done, but not necessarily something else. And I think having them own more of that prioritization process would have really helped us a lot in progressing what we've done.
I think the thing that I wish we could do it better, and I don't know how I control it, but it's the pace and the duration of time. By the time you get into a project, not only leading up to the launch where you say, okay, we're going to do it and we start, it could be 3 to 4 to 5 years. And think about a healthcare organization and the amount of change that the organization and the environment and the regulatory environment and the payer environment and managed care, non-managed care, ACOs, non-ACOs, and how the industry is moving. So when you're trying to drive transformation like we do with a big EMR implementation, for example, you're talking about you need some focus and you need a lot of attention on it. But there's times in this 5-year window where things go a little quiet and you can't keep everybody's attention level at 100% all the time. But it'd be great if you could compress it a little bit or introduce it in pockets to get to the better outcome. But it's that duration. People get ADD, we lose attention, things change, leadership changes. And so it's a little bit about the priorities, it's a little bit about the scope, but man, a lot of it has to do with the amount of time that you're kind of disrupting or trying to disrupt the organization.
And I want to support what Mark said, because I tell my folks all the time, we're not paid to make decisions in IT, we're paid to do stuff. So we force, and that's something I strongly believe in, we pull our leaders into the room and we make them make these decisions. Because, and I've said this before, do you really want me deciding how the lab works? Do you really want, a redneck from Tennessee really telling you this is how your lab should work? So we force them into that decision-making process, and right, wrong, or indifferent, it's the business, it's their system and not IT system. IT didn't make this decision. We don't want to make that decision. But that, I think a lot of failures happen in EMR rollouts when we say, we get paid to do stuff, we get paid to make stuff happen, so it's not going fast enough, and we end up by proxy making decisions that we shouldn't make, and in the end it turns out bad for us. So I totally support what Mark was saying, is that the business needs to be heavily involved, the business needs to be making the critical decisions, and we need to be making it happen.
So I hear a lot of themes about teamwork and communication and involving people in multiple decisions, which I have heard several answers throughout it. Well, we have reached the official end of our panel this afternoon, and also the end of the South Carolina HIMSS meeting. So I want to take this opportunity to thank Dr. Daniels, Dr. Shalkham, Skip Rollins, and Chris Belmont for their wonderful insight today. I learned quite a few things, and we certainly are all wiser because you shared your experience. So we very much appreciate your time today. There is a survey for our panel session, and I would encourage all of the attendees to please complete it. And thank you again for your time and your support of South Carolina HIMSS. Have a wonderful rest of the day.
Thank
you
you
so much. Appreciate it.
Thank you.
Thanks.